Time to restart for the afternoon session. Good to see everybody again. Now we get to talk about the emergency department without having to worry about sergeants, the good thing, probably. Um, so, one thing I just want to acknowledge is, we actually have a lot of new people, who are entering medic, and this might be your first meeting. So, welcome, and, certainly ask questions along the way. We have a certain format for sure that a lot of us have gotten used to. If you'll start to review how that is in our meetings. Here's the agenda. We'll provide a lot of kind of status checks on our quality improvement work. This will be familiar certainly to how we do things in general with our meetings. Some announcements. We'll also talk about a new quality initiative that we're going to launch in pediatric readiness. We'll level set what that's like. And then even better, we'll close out the meeting with some presentations from our sites about some of the improvement work that they've been focusing on. You get to hear some really good examples how folks are approaching problems that ideally we can all learn from. So actually I want to start here. I'm curious, we're curious to hear from all of you about what this morning was like. We don't have an agenda here. All feedback is good feedback. Certainly if there are good things to say, great. If there's some bad things to say, we want to know about that too. Probably even more important, we want to know about that too. As these opportunities present themselves to us, thinking about joint meetings in particular, we want to have your feedback as we, think about anything in the future. So I'm going to stop and, okay, good, staff.
I'll start with pros. No, I think it's interesting to see another program and the progress that they made is all established. That feeds some energy in one part of the big times as far as collaborating with that group is that's kind of a very thin sliver of overlap. And I think that we were all struggling to find frequent ideas of this. The last time I saw me.
Yeah.
We have a process and we see these patients kind of way. So I thought that we had a lot of shared learning. You're the most patients out we are actually collaborating on patients. And we are.
Yeah, that's perfect. Yeah, I definitely hear that. I think that's something that we were struggling with at times we were planning into, and some of what we wanted to also create like foundation for like the general problem of post-op, general surgery patients with bariatrics as a specific case use. But for sure, it's hard to get that formula right. Great comment. Anything else? Oh, yeah, Josh. Okay.
Earlier presentation,
Good. Good. Yeah, sometimes you wade through a lot of like people talking at you to get to the stuff that's really helpful, but I'm glad that works. At least the concept of that works. Good. Definitely.
I really appreciated another application and what that MBSC data center can do. And understand about helping us understand the post-op and pre-treatment care of certain patients and how do we help navigate patients where they need to go. I think for us, and we're just care specialists, it was very interesting because we have a clinical setting that is really specifically targeted and trying to provide the services and understanding the population after the data sharing. So I have a list of follow-up questions. And then I just think the more we can understand that data can do for us as teams.
Yeah, I appreciate that because they certainly are available to us. I kind of made a joke they're a consult. But yeah, I mean, they can help us enable these kinds of, understandings and solutions. Good. Oh, yes.
The joint section with the problems that you're addressing Well, I'm not sure that each one, we kind of all came up to the same things. Yes, the communication, but then like having a system in place, whether it's a bariatric surgeon or whatever, that really supports, getting from where you are to where you need to be in a sense.
Yep.
And then also having, when we're having such decrease in resources as it's going on, how to support that change, you know, and communicate it so that everybody buys in.
Yeah, I hope that's a major lesson, like, you know, the problem of communication, how do you standardize that? But I'm glad like those kind of things came up and you guys worked through them. Yes, in the back.
So it was very interesting, at least a large part, not all, but a large part of, that fees are avoidance of overutilization within the emergency department. You know, it's interesting to collaborate from a bariatric surgery perspective with overutilization of the emergency department. And both things I think really highlight how healthcare is a team sport, and we rely so much as well on our primary care colleagues, and in terms of avoiding patients that perhaps aren't best served in an emergency department setting, and how do we involve our primary care colleagues, patient selection coming to the emergency department in the first place, how do we improve access to those primary care services?
Yeah, and it's really great if those were the kind of conversations you're having. I think. This is maybe unfair, but I don't think surgeons really understand what the care processes are like, in the day-to-day ED, and providing some understanding of like how patients think about their symptoms and their problems. Hopefully, gonna help their processes. Awesome. So I was hearing probably bariatric was a little hard to mix in with like, our book of business, but at the same time, perhaps some value add for some of the things that were done. Some of the ways we structured at least to make sure activity was good. Appreciate that, and certainly like any other feedback at any point, please give it to us. We want to listen and learn. Okay, so a couple announcements. First, so one of the things that we've been doing as a project within MEDIC through some grant funding that we have from the Department of Health and Human Services at the state is implementing opt-out screening programs for HIV and emergency departments across the state. And one of the things that we support with that is what we call a learning series, basically a set of seminars that we sponsor. And the next one is actually next week. And we're going to hear from Kristen Spohr, who's a emergency physician at Hurley, about her program. So just a general call for those that are interested to attend, please do so. You can see the registration information up there. And then a really cool announcement is that Terry, who is supposed to stand up, so we can recognize her, I think is officially retiring today. No. Okay, 2 more weeks. Okay, fair enough. Okay. Okay. So Terry's been with us since like the original, medic in 2017, more than 50 years in nursing. So we just want to recognize her with us. Awesome. Okay. So now we're gonna go through some of the level setting on where we are in our quality improvement work. We present this table every time. It's a useful way to just kind of think about the timelines. The performance is a little trickier to interpret just because I think in particular, in 2025, we're actually onboarding a lot of hospitals who've never done improvement work with MEDIC before. So even though the numbers look a little bit like we're getting worse, I think that's not true because of the ways that the sites are coming on board with us, but you get a general sense of where we are in our work. We showed some of this information at the morning meeting. But I want to just call out a few things more specifically. So this is a slide that's gonna be like each quality initiative. And, we attempt to describe at least the impact of our work in the form of avoided, low value testing and some of the costs related to those, tests that we potentially save. So this is, for pulmonary embolism, over the few years of this quality initiative. This is the impact across the head injury, adult measure in, scans avoided and costs saved. Chest pain has a big impact because at least the way that we think about the avoidable costs is, you're saving really a hospitalization, which of course, is a big spend. And so that begins to build quite a lot over time, as we are better at discharging low risk chest pain patients. And I think, Michelle, you're gonna talk to the piece stuff, right? Yeah.
Really gets into the functionality. We're still at usually impact. Things and reducing mortality, and in this case, I'm going to process without any so usually for our PT,
Then we have, the more public health work. And within, the medic sites in particular, focus on naloxone distribution. You can see the total numbers of kits distributed, over the years. We now approaching, more than 2,500 kits up through 2024. And then the other numbers here relate to smoking, counseling cessation, events, in the sites that are doing that. That's something related to this BVR program. So it's not all sites engaged in this work. So now we're gonna work through just like our current, improvement work within these, BVR and P4P programs. So we're just gonna show you a set of slides around the status check on those. The measurement period for these start in September and will go through, August of this year. So just to give you a sense of like where we are performing as a group. So for this one, we're looking at adult head injury. We're in the green territory, so in the target range.
Similarly for chest X-ray, we are on strength. Problem is that if we set it on our chest X-ray, we look at the P4P. We have a little, remember, this is now, each site is individually countable, so it's not weighted. So now we have a lot more variation. So my message to everybody in the room is chest X-ray. We need to get our chest X-ray titer downward for the remainder of the year. As you can see, we can't see the 3 months that are still like hasn't settled in the dust yet. You have another 2 months to really get this picked up so we can get our chest.
Naloxone is actually doing pretty well above the target range. Certainly always room for improvement, but with respect at least to the thyroid measure, we're doing quite well. PE is always the trickier one. We're presently like right on the edge of meeting the target, which is diagnostic yield, over, equal to over 8.5%. The group were at 8.3%, so it's close. But certainly it's gonna need some work to get probably above that target. You know, one thing I was called about PE, you know, we've had conversations in past meetings about, you know, the challenge with this measure is it gives you kind of the sum or the outcome, but doesn't necessarily tell you like how to get better. We've really built out intentionally a set of reports to help you figure out where your opportunities might sit. Some of which we've listed here and talked about in the past, you know, the age adjustment, interpretation of D-dimer, the more D-dimer first approach to the diagnostic testing pathway. If you want to reach out to us and set up a call, we'd be happy to talk through these reports with you individually. We've done this actually with a few other sites. I think they view that as really helpful to their cause. So just a general offer, if you want to do that, we're happy to set up a meeting with all of you and talk through that. Again, not every person, oh, great question, yeah. Yeah. Sorry. Yeah, so the question was around what's the target, how do we sort of determine the target? So we actually do a entire sort of P for P, VBR conversation that includes like what measures are in those and what are our targets with the executive committee. We do this annually. We're actually just had our meeting, first meeting for this morning before the 5-wide meeting launch. We'll have a follow-up meeting for this later this month, where we work through exactly these questions. We take a data-driven approach to setting those targets based on how sites are performing currently. When we think about cloud-wide meetings, we tend to set them at the median performance level, so where people are in the right down the middle. If we're talking more of a site-specific one, we look at where the top third of performance is and use that more as the target. We have a very standard process, so it's not just the coordinating center that's making up how we approach this, but it's a joint discussion with the executive committee to work through those decisions. And that's where the executive committee really makes an impact in sort of how we decide as a group to do these kind of programs. So I appreciate the question. Hopefully gave you some insight into the process. The last one here is grouping cessation. Not everybody does this. We measure this at the site level too. This is the group level. We're looking for enough in a 3-month span or 1 month with a higher performance to say that you met the target for the VBR program. So I think we're going to talk to this yet.
So everybody knows now we are going to do this asthma bundle rollout. Remember, that's a bundle. And we want to give people a sneak peek in what we're seeing in the data now. And you know, what you're seeing here is just, you know, how we're performing, like just taking a look at the data. And then remember, the 3 parts are finding, you know, delivery of steroids, bronchodilators, but also having asthma to deal with documented clinical, which many folks don't have outside of children's hospitals. So that's why you see a lot of the sites which are represented on those dots, kind of the 0 line. So nobody should fear this. This is an expected kind of view of what's happening right now. But we want to give you a sense about, you know, where things are. There are some hospitals, not just children's hospitals, who are beginning to employ an asthma tool within, you know, their PD. So we are starting to see more dots in that direction. But I just wanted to give you, you know, a sneak peek forward. So a little bit more granular, we're going to talk about, like, remember, it's a 3-part bundle, and there's basically about 5,000 cases already, you know, that we've seen up till this point, baseline year. And basically, we know that the children's hospitals are going to be, you know, a large majority, but they make up about 56%, which means there's a good amount of people out in the general hospital. I'll bet at your individual hospital, few, but collectively, you represent represent a good half of the data that we're about to employ for this baseline data level. And about 83% of those meet at least getting one part of them. And about 63% get, 2 out of the 3 on. And about roughly 20% get, the full bundle. So we're dealing with some numbers here that are, a bit different from what we're used to, because this is a bundle approach, but we just wanted to give you some sense about it, and nothing here is, unexpected. And so a little bit more about like those, which parts of the bundle matter. And so about 30% had serial asthma, scores document. And that, again, is no surprise. That is the one that we expect literally, well, to just a little bit of, let's get a document of a score that we can then use over a couple, measurements in ED. That number's going to go up pretty quick as soon as, we're citing, working on it. 55% had timely administration of steroids, about 71% had timely administration. So that's what we're seeing now. Still have several months, obviously, the data collection to go, but this is where our starting point is. And I think there was a question about, how to set targets. I believe we will be, looking at that closely. We can't set targets that are in the stratosphere. We know where we start down here. So they'll be pretty weird.
All right, so I'm gonna switch into a different topic. We try to do this at least once a year. We think this is really important kind of conversation and something that we think it's important that you all are aware of too. So there's a concept in quality improvement called a balancing measure, where we want to be sure that as we make our improvements, that we aren't causing any unanticipated harm or adverse safety as a result of the improvement work that we're doing. And so this is called a balancing measure. And so we are monitoring this in the background. We've actually built out reports that are accessible through Tableau that you could actually yourself go in and see what your site is doing with these balancing measures. And I'll talk through each one kind of one by one, sort of point out the concept and also how we've been doing. So the way that we think about a balancing measure with the head injury work is, for those cases where an individual does not receive a CT for their head injury, are discharged from the emergency department, what's the possibility that that individual turns out to have a severe head injury that was not diagnosed the first visit, came back to the emergency department within 7 days and got that diagnosis. So that's what we mean by a balancing measure. It's a way to monitor harm and safety in the background. So we looked at our data. This is cloud-wide data for all of 2024. And what we found was we had no cases that met that criteria for the adult head injury measure. So that should at least provide some good news, some kind of backstop understanding that we aren't causing harm, even as we're doing more appropriate CT testing for adult head injury. We had the same kind of balancing measure applied to children, and that's what the second row is about. There were 3 cases that this occurred at. We are going to want to look into those cases and understand a little bit more about the details there. So we'll probably reach out to the sites that those were involved in, and sometimes they are the kinds of problems that once you learn a little bit about the case, you may not feel like there was a miss here. But regardless, the numbers are like quite low. We didn't even put a percentage because it's like less than like 0.05%. So the rate's impressively low. We have a similar kind of concept for the balancing measure for low-risk chest pain. There's a definition out there called MACE, major adverse cardiac events. These are events like an acute MI, a cardiac arrest, somebody that is in cardiogenic shock. So we look for the frequency of these events in individuals being discharged home from the emergency department who are low risk. for their chest pain. And we look for return visits to our emergency departments in the network within 30 days. So that's the MACE rate. I think most people believe, at least kind of out in the literature, that this rate should be less than 1%. You know, of course, like it's impossible to get perfect in general in healthcare. And so most people feel like, you know, the risk tolerance is around 1%. And this is, again, 30 days. So it's not like they're coming back to the emergency department in 3 days. There's a lot that's going on, probably related to their care in that 30-day period. But regardless, I mean, you know, 11 cases out of 11,000. Which I interpret is like an incredible margin of safety here. And hopefully you feel secure in this as well. This is our balancing measure for the pediatric chest X-ray work. We have a couple different concepts here. The top one is kids diagnosed with asthma, bronchiolitis, or croup, who did not get an X-ray, were discharged home, and came back within 3 days, and had a diagnosis of pneumonia at that second visit. This one's a little trickier to interpret. Doesn't necessarily mean, to be honest, that that first visit had inappropriate care. You know, somebody may not have had pneumonia when they saw it first time. They can develop pneumonia later. You have to sort of interpret that, at least in that context. Nevertheless, I mean, I think it's a useful way to benchmark ourselves. So that is happening, you know, 0.5% of the time. And then the bottom row are, again, these individuals. They're not getting an X-ray, came back in the 3-day span, and this time they were admitted. So a little different definition, but so that you probably get that concept too. I think what's important with these measures is to benchmark them across time and understand like the intersection between, or the relationship between our improvement work and any changes in these balancing measures. So in the light orange, that's our chest X-ray improvement rate. So across the network, it's going down because we're doing less chest X-rays. And I think as I interpret this, it doesn't seem to be impacting or causing harm in that we're not seeing a tick up in these return visits with this diagnosis of pneumonia. This is a kind of figure graph that you can see actually on your balancing measure reports through Tableau. Here's another way that we look at this, which is folks, kids diagnosed with asthma, discharged, who come back within 72 hours with an admission to an ICU or a transfer. This is in the sort of asthma cohort. We're focused on kind of steroids and now this bundle approach. Also a pretty frequent event. So I'll pause there. Awesome, we got a question.
Issue question.
Yeah.
Is it safety tiering?
So we are not always able to track across the entire network of EDs because we can't always have like a unique identifier link. So within the health systems that share medical records, have the same medical record number, we can do that linkage. So we can for some, where it's more of a health system approach, but others, it's only their own ED return. So there is a limitation there for sure. Yeah, good question. Any other questions about this? Definitely, you know, catch us also, like if you're curious about how to get into these reports, you know, you can access them, you can actually identify cases, and you can, you know, use that information to get into charts and sort of understand the details of the care a lot more too. All right, a couple more updates. For those that track this stuff, and for those that are new to Medic, we have a committee who's responsible for helping us vet through uses of the data for research and scientific applications. We also have some grant-funded studies that are going on using the Medic network, and so we use the data publications committee for sorting through all that work. and have had a few publications come out. This is about this, medical RPE study that some of you are participating in, and thank you for that. We've had a couple presentations at some spring meetings, one focused on the pediatric readiness. We had, an abstract at SAM from a medical student at University of Michigan talking about using the registry to understand wait times for patients in the state of Michigan. And, Katie presented at the Emergency Nurse Association conference in the state about pediatric readiness as well. And then we have actually a couple of grants, going out related to using medic data and medic registry, information as well as the network. Talking a lot. But there's a couple more things, and then we'll get into hearing from, local sites. Everybody's favorite, process, just a reminder that if you are participating in the VBR program, this like 2% program, Katie sent an email out pretty recently in the last couple of weeks, about how to participate in this program. This is the one that requires, all your physicians to log into Tableau and submit, a survey about that. You have until September, end of September to get this done. Most of the time, people wait until like the last week, to get it done. Okay, it'd be nicer if, that happens earlier in the process. And the goal here is really for folks to access their own data, learn from what they're doing individually. So earlier tends to be better, at least, from that perspective too. But just, if you have any questions about that, reach out to Katie. Something new to talk about. So we, updated the executive committee this morning about this. Medic is getting into the stroke, improvement business. We, have secured some funds from Blue Cross to build out a portfolio of quality improvement work within the condition of stroke. I think from Blue Cross's perspective, they recognize that nobody in their portfolio of work is focused on stroke care. And of course, stroke is a really important condition, causes a lot of morbidity, a lot of long-term disability, some of course costs related to all that. And really access to stroke care begins in the emergency department. This is how people, access the healthcare to get their stroke treatment. And so we're starting to build out, a strategy around this. We're early. This is gonna look a little bit different because, we're gonna have some partnerships that we have to establish, outside of the walls of the emergency departments, neurology, neurosurgery, the proceduralists that do thrombectomies. That's gonna be part of this work. So you will hear more, but we will keep this front and center, on the emergency department, because that's where good quality stroke care begins. The sort of timeline there is a general understanding of this. We're aiming to begin data collection probably in 2026. We would begin to think about quality improvements until 2027. And we also recognize that hospitals are already doing a lot of this work locally, and we don't want to duplicate or disrupt that. So we're gonna be sure we get aligned, with, hospitals as they approach this work, and certainly with all of you as well. So a whole lot more to come here. Nothing to do right now, and we will keep you, up to date and engaged, as our process works. Our vision, is to certainly focus first on the emergency department. And the scope will start, as patients are accessing care in the emergency department. So probably not focus as much on pre-hospital stroke care, even though it does obviously impacts or how stroke care is delivered in the emergency department. Also work through the treatment side of it mentions thrombectomies, that's gonna be part of this. And then as the care cascades in the hospital, also the quality of that, particularly around secondary stroke prevention and the discharge process. So that's gonna be the scope. And that's part of what I'm saying is we're gonna have to build a bunch of new partnerships here. As I said, nothing for you all to worry about right now, although we're happy to have conversations. If you're curious about the process, and we will definitely keep you up to date as things move along, and keep you, engaged, as, obviously key stakeholders here. I'll pause there. I mean, I'm happy to have any questions about this. I mean, certainly I don't have a lot of specifics yet. But certainly, if you're curious about vision or strategy, yeah, sure. So I think the question was, do we have bandwidth to bring on new quality initiatives or still doing other quality initiatives? I think that's a really key point. And we will be sure to try to keep this in the bandwidth around this, fair. One of the things that we work through with the executive committee is not all the measures or all the initiatives are being, incentivized and say P for P or VBR in one given moment. A lot of times we give options for sites to choose. And so I think these are ways that we can do our best to make sure that this is a fair, expectation of work. But I definitely hear what you're saying. I think it's a really important point. All right. I'm gonna stop talking. Think it's your friend. Yeah, okay, awesome. Yeah. All right.
Hi, everybody. Okay. For those of you who don't know me, my name is Emily Mathias. I am a pediatric emergency medicine doctor at University of Michigan. Obviously I'm not. And I also work with Medic. And I've been for the past about year and a half on their pediatric readiness initiative, which I'm going to talk a little bit about here. We had an opportunity to talk about this quality measure rollout this morning to the executive committee, and now I'm going to introduce. Just a little timeline of what's been going on, and how Medic, or how we kind of evolved this program. So started last year in April, we got a year of funding for a pilot program. And during that time, the year pilot, we got 6 Medic sites to enroll. And actually a couple of those sites are going to be talking this afternoon. I hope you can stick around for that. Some really great presentations on what they've been able to accomplish. But yeah, so we developed this program surrounding improving pediatric readiness at these sites. And talk a little bit more about that later. So this slide more or less is serving the purpose of saying that there are lots of different people in the pediatric readiness space. So on the last slide it said, so last year at the spring collaborative wide meeting, Dr. Sam, she doesn't know last name, I'm gonna butcher it, so I'm not gonna try. But she talked, so maybe you remember hearing about pediatric readiness from her. There are lots of national groups, such as the National Pediatric Readiness Project. They're the ones who kind of develop the pediatric readiness assessment, which is part of what we measured during our pilot program. But they're beyond the Pediatric Readiness Project. We have Michigan groups. We have the Michigan MBSC, which is a state partnership program, a little bit of like a branch of that national program. And then you may have pediatric readiness efforts going on locally within your institution. And all of this is to say is that at Medic, we're aware of all of these programs. We are working with them. And again, just as like, generally speaking, we are working with them in a supportive role. So after a really successful pilot year, a little biased, but it went really well. We got a lot of really good information, good data, good feedback. And it helped us to develop this into now it's going to be a new quality measure through Medic. And so it's going to look a little bit different than the typical quality measures. There's, at least at this time, no data extraction plan, but it's going to be in a 3-year cycle, which your site is going to be assigned to either one of the first 3 years, 26, 27, or 28. And during that time, we're going to, that quality measure is going to replace another site-specific measurement in part of your P4P. So, or P4P scorecard. So, kind of how we're planning on doing this is that and again, this is from feedback from our initial pilot year. We will conduct an initial in-person baseline survey, parts of our staff, parts of your staff. We've identified some key stakeholders, including the ED nurse manager, anyone who is filling out a PEC role, which is, or anyone, a nurse position, ideally both, and then, a trauma program coordinator. So for anyone who's familiar, stands for pediatric emergency care coordinator, and it is a role that a lot of us should have. And then after this in-person baseline, you're going to get you're going to get a score from your pediatric readiness assessment. Again, this is it's through the National Pediatric Readiness Project, but we use the assessment that they have available because it is validated, evidence-based, and it kind of it provides you with an actual number, an actual score, and a gap report. So some actionable items. So we're going to work through that with you, working through some QI cycles, and then with some like narrative report updates. And then at the end of your year, we're gonna do a virtual follow-up. So kind of talk through this a little bit, but it's a little bit different than some of our other QI measures. The basic P4P incentive structure with partial points for improvement and then full points for meeting the target. There's going to be no change to the total number of measures the site's going to be graded on in a given P4P year. I guess that's kind of like fit in, and then another one will be out. And then in your PEDS ready year, you're going to still have the monthly narrative report updates. And you're going to be supported by the medic staff throughout this. And then it's different from our other QI measures in that this incentive is not tied to performance on a specific clinical outcome measure yet. And then there's no, like I mentioned before, no traditional data abstraction. And then also we've come to realize that we really rely on engagement from roles outside of the ED. So like the trauma program, and they're going to need to be involved to make this work successful. And then it's that 3-year cycle, and then we're going to have the first visit is going to be an on-site visit. You know, it's a lot, but any questions from anyone? And then again, I hope you can stick around for it. We're going to have a couple of our pilot sites talking through their process of going through this PEDS readiness pilot with us the past year. A lot of just really powerful stuff. Any questions?
Or we already know when they're outside of these.
We do not have, we're working on that. We do not have the specific, yearly cycle. Like I mentioned before, the reason that it wasn't just literally just like random years is because we're trying to align that closely with your ACS verification, because PEDS readiness is something that's part of ACS verification now for level 1 and level 2 trauma centers. Okay,